Committee will come to order. Without objection, the Chair is authorized to declare recess of the committee at any time. We will take this a little bit out of order today as we walk through this. We have some of the Democrat members that are on their way here, but we will begin the opening statements and allow them to be able to catch up. This is a subcommittee hearing on energy policy, health care, and entitlements called Medicare Mismanagement, Oversight of the Federal Government Effort to Recapture Misspent Funds. I would like to begin this hearing by stating the Oversight Committee mission statement. We exist to secure two fundamental principles. First, Americans have the right to know that money Washington takes from them is well spent. And second, Americans deserve an efficient, effective government that works for them. Our duty on the Oversight and Government Reform Committee is to protect these rights. Our solemn responsibility is to hold government accountable to taxpayers because taxpayers have a right to know what they get from their government. We will work tirelessly in partnership with citizen watchdogs to deliver the facts to the American people and bring genuine reform to the Federal bureaucracy. This is the mission of the Oversight and Government Reform Committee. Medicare currently pays 1/5 of all health care services provided nationwide, making it the largest single purchaser of health care in the country. Unfortunately, every year the Medicare program wastes an enormous amount of money in overpayments, fraud, and unnecessary tests and procedures. According to the Government Accountability Office, in 2013, $50 billion was lost to improper payments, an increase of $5 billion from 2012. Medicare fee-for-service accounted for $36 billion of this total. GAO has related Medicare as a high risk since 1990, in part due to the program's susceptibility to this waste, which make up a staggering 47% of total improper payments identified by the Federal Government last year. Growth in Medicare misspending and fraud represents a significant threat not only to the 50 million beneficiaries who depend on its services, but also to the program's finances. At present, the Medicare Trust Fund has been in deficit since 2008, and the Medicare actuaries predict the fund will be fully depleted by 2026. The Centers for Medicare and Medicaid Services has the responsibility to maintain the program integrity of Medicare. To combat fraud, CMS works in partnership with several outside organizations, like the Healthcare Fraud Prevention Enforcement Action Team, which operates Medicare fraud strike forces to combat perpetrators who often steal identities and falsify billing documents. The agency recently implemented a risk-based screening to identify fraudulent Medicare providers and suppliers. In April of 2014, CMS also announced that fingerprint-based background checks would be conducted on high-risk providers. Temporary enrollment moratoriums have also been placed on some new Medicare providers and suppliers in areas that are high risk for fraud. CMS has even begun administering risk-based private sector technologies like predictive analytics to identify possible fraudulent claims for review. CMS also relies on 4 types of contractors to combat improper payments. These contractors, such as the Recovery Audit Contractors, or RACs, review claims to identify overpayments and then recover the misspent funds. GAO and others have found that these contractors' efforts sometimes overlap and the requirements for responding to audits are not uniform. This puts a greater burden on providers. The GAO has recommended that improving consistency among contractors would improve efficiency of post-payment reviews of Medicare claims. Once improper payments are identified, CMS may take steps to reclaim identified overpayments. Providers and beneficiaries are given an opportunity to appeal these determinations through a lengthy appeals process. This third level of appeal is administered by 66 administrative law judges at HHS's Office of Medicare Hearings and Appeals. There is currently a massive backlog of over 460,000 pending appeals for ALJ hearings. Due to this backlog, HHS has stated it could currently take up to 28 months for a hearing before an ALJ, during which providers have their money held by the government. Not many businesses can survive having their money held for 28 months while they wait to decide if they are actually going to get reimbursed. The committee invited Chief ALJ Nancy Griswold to testify today on these issues, but she was unable to appear, but we will follow through on that. Today we have 3 witnesses. Kathleen King, Director of Health Care at the Government Accountability Office, Brian P. Ritchie, Acting Director Inspector General for Evaluation of Inspection at HHS Office of the Inspector General, and Dr. Shantu Agrawal, Deputy Administrator and Director for the Center of Program Integrity at CMS, to discuss how CMS can improve Medicare oversight and program integrity. I look forward to their testimony. The American people deserve a government that protects their tax dollars and uses them wisely. We must do more to strengthen the integrity of government programs overall, but particularly Medicare, given its enormous size and scope. Clearly, more needs to be done to improve the Federal Government's efforts to recover $50 billion in overpayments and other improper payments. I hope today's hearing will provide the subcommittee with some clarity about these areas. But the process cannot drive up the cost of health care for seniors and reduce their options for care. I look forward to the conversation that we'll have today. With that, I recognize Ms. Lujan Grisham for an opening statement.
Good morning. Thank you, Chairman Lankford, for holding the hearing. I agree with the Chairman that reducing waste and fraud and abuse in the Medicare program is critically important, not only to protect taxpayer funds, but as you just heard, it's also incredibly important to protect the health of our nation's seniors and disabled adult population. Now, we've got more than 10,000 seniors aging into the Medicare program each day this year. It is now more important than ever that we ensure the integrity of Medicare funds and keep the Medicare promise alive for generations of future Americans. Now, I'm grateful to have Mr. Ritchie here on behalf of the Department's Office of Inspector General to speak about the OIG's efforts to do exactly that. The OIG, in conjunction with the Department of Justice, prosecutes some of the worst instances of health care fraud, providers billing for non-existent beneficiaries or services that were never provided, and providers who order unnecessary or, in fact, harmful procedures. The Health Care Fraud and Abuse Program, a joint program under the direction of the Attorney General and the Secretary of the Health and Human Services Department, is a model for interagency cooperation and coordination. In fiscal year 2013, the HCFAC program recovered a record $4.3 billion in health care fraud judgments and settlements. This is remarkable. I look forward to hearing from the Assistant Inspector General about how this was achieved and what can be done to strengthen the program going forward. But I also think it's important to underscore what we've heard is that these bad actors represent a small fraction of all providers. A vast majority of providers are not fraudsters and are deeply dedicated to the care of their patients. And given the size and complexity, the theme of Medicare programs, overpayments are going to occur, and CMS must be vigilant in detecting and recouping them. But well-meaning providers are entitled to have their claims administered fairly, efficiently, and without undue delay so that they can focus on the core mission of providing care. And I have some serious concerns that the current system of post-payment audits by RACs is resulting in a significant burden on some providers, particularly smaller entities. Smaller providers, such as durable medical equipment or DME suppliers, have more difficulty complying with RAC requests for medical documentation and may not have the resources to, in fact, even appeal overpayment determinations. The considerable backlog in the Office of Medicare Hearings and Appeals only makes these matters worse, as these providers and suppliers do not have the luxury of waiting months for their appeals to be adjudicated. I also have concerns about how RAC audits may affect beneficiaries. As a representative of New Mexico's 1st District, the issue of access to care is always paramount in my mind. If a provider or a supplier is forced to cut back services or close its doors as a result of a RAC audit, I think this is a lose-lose situation for everyone, particularly as we're working to build access to care, particularly preventative care for these populations. Now, CMS recently announced that it will implement several changes to the RAC program, which will be effective with the next RAC program contract awards. Now, I look forward to hearing from Dr. Agrawal about CMS's efforts to improve the oversight of the RACs in particular. I hope that you will also address some of the issues we've both raised, the Chairman and I, regarding the burden on Medicare providers and with a particular focus on some of those smaller providers or providers in rural and frontier states like mine, and the impact that that has directly on the beneficiaries who are working to access those services. I also look forward to hearing from all of the witnesses about what CMS is doing to move away from the pay and chase model to a more proactive model that identifies improper payments up front. Such a model would spare both providers and taxpayers from expending resources that could be much better spent on providing care, which in the long run shores up Medicare for future generations. With that, Mr. Chairman, I yield back.
To Mr. Meadows for an opening statement.
Thank you, Mr. Chairman, for holding this hearing, and thank you for continuing to highlight that we need to make sure that the American taxpayers' money is well protected. This particular hearing is of importance to me primarily because I have some constituents that have been caught up in this ALJ backlog. And as the ranking member just testified, it can be extremely difficult on small businesses. The request for a particular company in my district threatens to put them out of business, and yet all they want is a fair hearing. I shared this with the chairman and shared some of my concerns that where we are, and in his own opening statements, he talked about the fact that we have a 28-month backlog. Well, actually, it's worse than that. If you look at the real numbers, that today, if we hired, according to the budget request for CMS, if we hired all the adjudicators, it would take close to 10 years to work through this backlog. A million appeals. And if you look at the rate, and actually the adjudicators have been improving their efficiency. They've been getting better year after year. And yet what we do is we have a policy of where we're saying you're guilty until proven innocent. Now, we're all against waste, fraud, and abuse. But what we must make sure of is that we do it under the rule of law and that we have laws that guide the guidelines that are there. There is a law right now that says that if we ask, if a constituent asks for a hearing, that the law says that they should have some kind of adjudication and a decision within 90 days. And yet, even according to the website there for CMS, we're not even opening the mail for weeks and months and months and months. So it's not even being put in terms of on the docket where it can be assigned to a judge for many, many months. We've got to do better than this and make sure that in this, we don't take those that are innocent and put them out of business. Now, I say that because if our overturn rate was not that great, we wouldn't have a problem. But according to documents, many of these appeals are being overturned by the adjudicators. Over 50% of them are being overturned. So you have over 50% of the people who are innocent, who are having to wait years for a decision, and in that, we must do better and we must find a better way to address this. So I look forward to hearing your testimony on all these things, and I thank you, Mr. Chairman.
Thank the gentleman for all of his work and his research that has gone into this hearing this day, and he's been a leader in this. Be glad to be able to receive the testimony now of our three witnesses. Pursuant to committee rules, all witnesses are sworn in before they testify. So if you please rise and raise your right hand. Do you solemnly swear or affirm that the testimony you're about to give is the truth, the whole truth, and nothing but the truth, so help you God? Thank you. Let the record reflect all three witnesses answered in the affirmative. You may be seated. Ms. Kathleen King is the Director for Health Care at the United States Government Accountability Office. Thank you for being here. Dr. Agarwal is the Deputy Administrator and Director for the Center for Program Integrity at CMS, and Mr. Brian Ritchie is the Acting Deputy Inspector General for Evaluation and Inspections at the Office of Inspector General at HHS. Thank you all for being here, and thanks for your testimony today. We've all received your written testimony. That will be a part of the permanent record. We would now be glad to be able to receive your oral testimony as well. In order to allow time for discussion, I ask you to limit your oral testimony to 5 minutes. You'll see the clock there in front of you. Ms. King, you are first.
Mr. Chairman and members of the subcommittee, thank you for inviting me to talk about our work regarding Medicare improper payments. CMS has made progress in implementing our recommendations to reduce improper payments, but there are additional actions they should take. I want to focus my remarks today on 3 areas: provider enrollment, pre-payment claims review, and post-payment claims review. With respect to provider enrollment, CMS has implemented provisions of the Patient Protection and Affordable Care Act to strengthen the enrollment process so that potentially fraudulent providers are prevented from enrolling in Medicare and higher-risk providers undergo more scrutiny before being permitted to enroll. CMS has recently imposed moratoria on the enrollment of certain types of providers in fraud hotspots and has contracted for fingerprint-based background checks for high-risk providers. However, CMS has not completed certain actions authorized in PPACA, which would also be helpful in fighting fraud. It has not yet published regulations to require additional disclosures of information regarding actions previously taken against providers, such as payment suspensions, and it has not published regulations establishing the core element of compliance programs or requirements for surety bonds for certain types of at-risk providers. With respect to review of claims for payment, Medicare uses prepayment review to deny payment for claims that should not be paid, and post-payment review to recover improperly paid claims. Prepayment reviews are typically automated edits in claims processing systems that can prevent payment of improper claims. For example, some prepayment edits check to see whether the claim is filled out properly and that the provider is enrolled in Medicare. Other prepayment edits check to see whether the service is covered by Medicare. We found some weaknesses in the use of prepayment edits and made a number of recommendations to CMS to promote implementation of effective edits regarding national policies and to encourage more widespread use of local policies by contractors. CMS agreed with our recommendations and has taken steps to implement most of them. Post-payment claims reviews may be automated, like prepayment reviews, or complex, which means that trained staff review medical documentation to determine whether the claim was proper. CMS uses 4 types of contractors to perform most post-payment reviews. We recently completed work that examined CMS's requirements for these contractors and found differences that can impede efficiency and effectiveness by increasing administrative burden on providers. For example, the minimum number of days contractors must give providers to respond to a request for documentation of a service ranges from 30 to 75 days. We recommended that CMS make the requirements for these contractors more consistent when it would not impede the efficiency of efforts to recover improper payments. CMS agreed with our recommendations and is taking steps to implement them. We also have further work underway on the post-payment review contractors to examine whether CMS has strategies to coordinate their work and whether these contractors comply with CMS's requirements regarding communications with providers. Although the percentage of claims subject to post-payment review is very small, less than 1% of all claims, the number of post-payment reviews has increased substantially in recent years. From 2011 to 2012, the number of these reviews increased from 1.5 million to 2.3 million. This is one factor contributing to a backlog and delays in resolving appeals by administrative law judges. We have been asked to examine the appeals process, including reasons for the increase, its effects on beneficiaries, providers, and contractors, and options to streamline the process. In conclusion, because Medicare is such a large and complex program, it is vulnerable to improper payments and fraud and abuse. Given the level of improper payments in Medicare, we urge CMS to use all available authorities for preventing, identifying, and recouping improper payments. This concludes my prepared remarks. Thank you.
Thank you. Dr. Agarwal.
Thank you. Chairman Lankford, Ranking Member Lujan Grisham, and members of the subcommittee, thank you for the invitation to discuss the Centers for Medicare and Medicaid Services program integrity efforts. Program integrity is a top priority for the administration and an agency-wide effort at CMS. We share the subcommittee's commitment to protecting beneficiaries and ensuring taxpayer dollars are spent on legitimate items and services, both of which are at the forefront of our program integrity efforts. I view program integrity through the lens of my experience as an emergency medicine physician who fundamentally cares about the health of patients. Our healthcare system should offer the highest quality and most appropriate care possible to ensure the well-being of individuals and populations. CMS is committed to protecting taxpayer dollars by preventing or recovering payments for wasteful, abusive, or fraudulent services, thus helping to extend the life of the trust fund. But the importance of program integrity efforts extend beyond dollars and healthcare costs alone. It is fundamentally about protecting our beneficiaries and ensuring we have the resources to provide for their care. As part of our responsibility to taxpayers and beneficiaries to see that resources are used appropriately, CMS has an obligation to perform audits, medical review, and use other oversight tools as a part of these efforts. I would like to make 3 points today about the status of our efforts. First, we are having real impact in reducing waste, abuse, and fraud in the Medicare program. Second, we continuously work to reduce provider burden while meeting our obligations to the trust fund. And finally, we continue to improve and innovate to meet our mission. On the first point, we're seeing success from our efforts to detect and prevent waste, abuse, and fraud. Through medical review activities, in fiscal 13 alone, $5.6 billion in payments were prevented from being paid or were returned to the trust fund. We've saved an additional $7.5 billion over the last several years from payment edits, which prevent bad payments from being made in the first place. At the direction of Congress, CMS uses the recovery auditors to perform medical review to identify and correct Medicare improper payments. Recovery auditors have returned over $7 billion to the Medicare Trust Fund since the start of the national program in 2010. Our anti-fraud activities have also had impact. Last year, HICFAC funding returned about $4 billion to the trust fund, resulting in an 8-to-1 return on investment. We have also revoked over 17,000 and deactivated over 260,000 providers and suppliers since passage of the Affordable Care Act. At the same time, we recognize these efforts can impose burdens on providers. CMS continually strives to carefully balance our responsibilities to protect the Medicare Trust Fund with our desire to limit the burden these efforts can place. To that end, we use tools such as educational efforts, data transparency, and significant contractor oversight to minimize burden wherever we can. We also engage in continuous dialogue with provider communities to improve our programs. As one example, during the next round of recovery audit contracting, CMS is making changes to the program based on feedback from stakeholders, and we believe will result in a more effective and efficient program with improved accuracy and more program transparency. We have also utilized other approaches, such as prior authorization, to reduce improper payments while granting more security and assurances to the provider community. We will continue to listen to stakeholders to make improvements to our programs. Third, we appreciate this committee's interest in ensuring that CMS is improving its program integrity efforts and know that the Congress and the public expect real and tangible results. To that end, we are also looking to implement new authorities or improvements which can enhance our efforts and impact. In July 2013, CMS imposed moratoria for the first time on the enrollment of certain types of new providers in geographic areas which have been prone to high amounts of fraud. With the moratoria in place, we've revoked the billing privileges of over 100 home health agencies in the Miami area, and we've revoked an additional 179 ambulance suppliers in Texas. We are also continuing to work with law enforcement in these hotspot areas. CMS is also using private sector tools and best practices to stop improper payments. Since June 2012, the Fraud Prevention System has applied advanced analytics on all Medicare fee-for-service claims on a streaming national basis. In its first year, the FPS stopped, prevented, or identified over $100 million in improper payments, including savings from kicking out bad actors. We've also begun to use the common private sector tool of prior authorization to address an area of high improper payments, the use of powered mobility devices. In 2012, CMS began a demonstration in 7 states to require prior authorization. This demonstration has resulted in a significant decrease in expenditures, over 66% in the demonstration states and over 50% in the non-demonstration states. Support from the provider community has been significant, many of whom have requested that CMS expand prior authorization to other parts of the country. While we know that we have made progress to address areas of vulnerability, we also know that more work remains to further refine our efforts and prevent improper payments and fraud. I look forward to answering the subcommittee's questions on how we can improve our commitment to protecting taxpayer and trust fund dollars while also protecting beneficiaries' access to high-quality care. Thank you.
Mr. Ritchie.
Good morning, Chairman Lankford, Ranking Members Grisham, and other distinguished members of the subcommittee. Thank you for the opportunity to discuss OIG's work on Medicare improper payments. Improper payments cost taxpayers and Medicare beneficiaries about $50 billion a year. Recovering these lost dollars and preventing future improper payments is paramount. In short, more action is needed from CMS, its contractors, and the Department. CMS needs to better ensure that Medicare makes accurate, appropriate payments. When improper payments do occur, CMS needs to identify and recover them. It must also implement safeguards to stop additional overpayments. CMS relies on contractors for many of these vital functions. This means that ensuring effective contractor performance is essential. Finally, the Medicare appeals system needs to be fundamentally changed to ensure efficient, effective, and fair outcomes for the program, its beneficiaries, and providers. My written testimony elaborates on OIG's work and recommendations in all of these areas. This morning, I'll focus on 4 key points that illustrate our work on these issues. First, CMS must do a better job ensuring that payments are accurate. For example, CMS needs to better protect Medicare and beneficiaries from inappropriate prescribing and billing for drugs. This is both a safety issue and a financial issue. We found that Part D paid millions of dollars for drugs prescribed by massage therapists, athletic trainers, and others with no authority to prescribe. CMS is working toward implementing several OIG recommendations to tighten up monitoring of billing for drugs. Second,
Mr. Ritchie, you might check your microphone there to see if it clicked off. So is it still lit up there?
Thanks. Okay. Second, when improper payments occur, CMS needs to do 4 things: identify, recover, assess, and address. CMS contracts with recovery auditors, or RACs, to identify improper payments. In 2010 and 2011, RAC audits resulted in more than $700 million in overpayments recovered. CMS also assesses the RAC findings to understand why the overpayments occurred. It then must address these issues to prevent future improper payments. My third point is that CMS needs to better ensure that its contractors perform effectively. CMS contractors pay claims, identify and recover overpayments, and protect Medicare from fraud and abuse. OIG has consistently raised concerns about contractor performance and oversight. CMS needs to assess performance more effectively and take action when contractors fail to meet standards. And finally, the Medicare appeals system needs to be fundamentally changed. Even before the recent surge in appeals and subsequent backlog, OIG raised concerns about the administrative law judge, or ALJ, level. ALJs overturn prior level decisions more than half the time. ALJs also vary widely amongst themselves in decision-making. This happens partly because Medicare policies are not clear. OIG recommends clarifying Medicare policies and then coordinating training on those policies at all levels of appeals. Administrative inefficiencies also contribute to the problem. We recommend that paper files be standardized and made electronic. In closing, more needs to be done to reduce and recover improper payments, ensure effective contractor performance, and improve the appeals process. OIG is committed to finding solutions to reduce waste, protect beneficiaries, and improve the program. Thank you for your time, and I welcome your questions.
Thank you all. I recognize myself for 5 minutes for a first round of questioning, and then we'll just go back and forth all on the dais from here. Let me set some context during my time that's here. If a provider will have something reviewed, let's talk through the process and let's set context for everyone on this. Go back to Ms. Luan Grisham's statement about the pay and chase side of this. So this is the post-payment has occurred. How will someone find out that they're going to be checked, inspected, whatever it may be, post-payment for any kind of claim? What's the step one? How will they be notified?
They get a letter from a contractor.
Okay, they get a letter from a contractor, that being with the RAC audit contractor, or that be who?
It could be one of 4 types of contractors. It could be a MAC, a Medicare administrative contractor. It could be a RAC. It could be the CERT contractor, which pulls a sample of random claims to estimate the improper payment rate. Or it could be a ZPIC, a Zone Program Integrity contractor, who is looking specifically for potential fraud.
Okay, so let's back up. Let's take a physical therapy clinic, standalone, privately owned clinic, seeing patients, mixture of insurance, private pay, and then also Medicare. Okay, so you're saying that one physical therapy clinic could receive a request to pull a file on from any one of those 4, or those 4 are unique for different entities?
They could receive a request from any one of the 4.
Okay. Is it possible that all 4 of them will make requests during the course of a year to pull a file?
It's not supposed to happen.
Is it possible?
Theoretically, but highly unlikely.
Okay. So how are they notified then if one of them does it, or could 2 of them do it in the course of a year, or could 3? You're saying all 4 unlikely?
The RACs are not supposed to duplicate reviews that have been done by other contractors.
Now, to the same provider or to the same case?
To the same case.
Okay.
They're
So
not,
could
a duplicate claim is considered to be the same file for the same service.
could a provider get a review from all 4 of those different folks, different cases, but that provider itself get reviews from 4 different groups of people from Medicare?
Possible, but it's unlikely.
Okay. So what about from 2 of those or from 3 of those? You're saying 4 is unlikely. Is it possible for them to get 2 of them?
Yes. Like, for example, they might get a review from a RAC, and they also might get a review from a CERT who's estimating the improper payment rate.
Okay. So when a RAC contacts them, how many are they pulling? How many files are they pulling at that point? Are they pulling 1? Are they pulling a sampling? How many are they going to pull?
They're pulling 1, I believe. You know, overall, the RACs did over 1 million reviews.
Correct.
But when they're reviewing, for a provider, they're pulling for that service.
Right, but they're pulling. We'll go back to our physical therapy clinic as well.
Yeah.
They're not going to reach in and just randomly grab 1 case, are they? They're going to grab a sampling of cases from them to be able to review?
No, I don't believe so.
So how do they select? How do they select which patient?
Well, in the
file
case
to
of the
review?
RAC, CMS tells the RAC what kinds of issues they can look at. They work together with CMS, and CMS approves the type of issues that RACs are going to investigate.
So they go in and make the request of a certain type
Yes.
of client that's there. But I'm saying they're not just pulling 1 patient, are they, from that type? They may pull 10, they may pull 20. How many are they pulling?
No, I believe the claims are investigated on an individual basis.
Right, but the provider, I'm saying to the provider, when they get notification from the RAC,
Yes. They'll get notification of a claim, investigation of a claim. I'm sorry. Correction. There could be more than 1, but there is a limit.
right,
on the
that's what I'm
number
trying to
that
get
they
is
can
what is that limit? How many are they trying to pull? Does anyone else know the number on that? How many are they trying to pull at one time for a RAC audit?
So if I might, Congressman, just take a little bit of a step back, because I agree that there are numerous contractors that can audit a single provider. Each of those contractors actually has, they are set in statute. They are supposed to do the job that they're doing. Right. The CERT contractor's function is different from the RAC contractor. The CERT contractor's function is to go in there and actually determine the improper payment rate. It's not primarily looking at the provider. It, of course, has to do the medical record audit to determine whether or not an improper payment has occurred, but it's actually a function to evaluate our services. While I agree that numerous contractors can touch providers, we also do try to coordinate not touching the same claim and not touching the same provider too often. In answer to your last question, we have set limits for RAC contractors so that they can touch a provider and request a particular sampling based on the size of the provider themselves.
Right. So how large is that sampling?
So just a hypothetical example might be a smaller provider that sends in, say, 10,000 claims a year. A RAC would be permitted to obtain no more than 20 to 25 claims at a time, and no more frequently than, I believe, every 45 days.
So they could come in every 45 days and pull 20 to 25, correct? Different files, and say, we're not going to pay these until we get a chance to check them, correct? Not correct?
I think conceivably that's correct. But again, we do provide oversight to ensure that we are not burdening individual providers or individual entities during the course of these processes.
Okay, I've exceeded my time. We'll come back to that. I want to be able to honor everyone's time. I do want to come back to that statement that we're not burdening individual providers. I could name you several dozen individual providers in my district that would beg to differ on that statement. Now, you will find no greater advocates for the taxpayers and going after fraud than us at this panel. But we're also advocates to make sure that we don't lose providers that our seniors still have access to multiple providers that are out there, that there aren't providers that say this is not worth it and drop out. I won't take Medicare anymore because it becomes so burdensome for them. So we've got to be able to do that. With that, I recognize Ms. Lujan Grisham.
Thank you, Mr. Chairman. And I'm going to do a couple of things, assuming I don't run out of time. I want to follow up on a couple of things that Chairman Lankford said. That balance is really tricky, and given that this committee clearly wants to focus on waste, fraud, and abuse, even if the Medicare program and every other health care program was flush, and that wasn't our being efficient and worrying about having services available for a growing population. Our job is to make sure that every tax dollar is being used the way it was intended. And we want bad actors and bad providers barred from this system and all others. No question about that. We also recognize that you have to do a due process system, and we appreciate that. But the due process system is clearly broken, because if you're waiting years for and without payment, or having that payment removed, that's not due process. And I would agree, too, that we've created a very burdensome administrative environment. It's not just the Federal touches for the Medicare program, although that is a federally operated. Remember that most of these programs take Medicare, Medicaid, they're serving dual eligibles. They're being touched, reviewed, audited, administratively regulated by states, and some states with a whole different variety of private entities. So these small, sometimes small providers are spending an incredible amount of time being administratively reviewed, and these recovery audits, given that there is a contingency fee where they're being incentivized to identify issues and problems. This creates a pretty ripe environment for what I think you have today, which is we've now, with the Office of Medicare Hearings and Appeals, we've recently announced that we're going to suspend the ability of providers to have their appeals heard by administrative law judges. The decision was made as a result of a massive backlog of appeals awaiting an ALJ hearing, which by the Medicare Hearings and Appeals' own admission has grown from 92,000 to over 460,000 in just 2 years. Now, Dr. Agrawal, I understand that the Office of Medicare Hearing and Appeals is not part of CMS. However, I also understand that your office oversees these contractors, including the RACs, whose audits are the cause of many, if not most, of these appeals. Given the long wait times for getting an appeal heard by, wouldn't it be prudent for CMS to suspend RAC audits until the claims backlog is cleared? And I want you to touch, Dr. Agrawal, on the fact that there are other ways to make sure that we are preventing fraud more than just the RAC audits.
Sure, thank you. So I would start at just agreeing with you that it is a real challenge in program integrity to make sure that we are doing our job, protecting the trust fund, and at the same time doing as much as we can to lower the burden on providers and make sure that there are no access to care issues for our beneficiaries. That is a top priority. It's something I said in my opening statement. I think it's also important to kind of level set a little bit on the amount of burden that we are placing on the system through our activities. As pointed out earlier by Ms. King, we audit far less than 1% of the claims that we receive. With respect to RACs in particular, there are clearly appeals that occur from RAC audits, but the overall rate of appeals from overdeterminations, the overturn rate from all of the overdeterminations is about 7%. That's in the latest publicly available data. If you look at just appeals that are initiated after an overpayment determination by a RAC, the overpayment rate is about 14% out of all appeals that are generated. So I do think that the appeals process is important for providers. It allows them an opportunity to represent their claim, to represent their interest, and it provides an important check and balance on our approach. As far as the third level of appeal that involves the ALJ, as you pointed out, that is not directly under our control. We have been working with the Department to devise strategies for that backlog. Well, what is directly under our control are the first two levels of appeal, and I can tell you that both the overturn rate is not substantially high in those areas, and the appeals are being heard in a timely fashion. There are numerous other kind of strategies that we've taken to try to decrease the appeals. I want to afford you your time, so I'm happy to go into them if you'd like.
Right, and I just want to, and I appreciate that, except that I would certainly make the statement that, and you've heard this, you'll hear this theme, I think, throughout this hearing, we have providers who would differ with you about these administrative burdens and whether 14% is reasonable in terms of what they can manage in terms of cash flow for their patients and staff. And I would also say that many of the smaller providers couldn't afford to appeal, so I'm not sure if this data is really relevant, and what strategies have you undertaken to identify how many providers certainly come to me, those providers, who would love to appeal because they believe that they've been wronged or there's been an administrative error but don't have the ability to do it. Also, I would say fear, intimidation, and retaliation, and just pay or do whatever it is that they're asked to do at the next level. And I'm way over time. So if you could respond to that, and then I'll come back.
Sure. In addition to appeals, Congresswoman, there are other controls that we have implemented over our contractors. We do determine what areas RACs can look at. They have to achieve, sort of get permission from a board at CMS to, before they enter into any particular audit area. That is a type of oversight. We have an independent validation contractor that looks behind the RACs themselves to evaluate whether or not they are making these determinations accurately. And all of the RACs have, through that validation contractor, achieved a well over 90% accuracy rate. I think the incentive structure itself actually incentivizes getting it right. So, RACs do get paid on a contingency basis, as you pointed out. But if they lose on appeal, they lose the contingency fee. I think that is an enormous incentive on the RACs to make sure that they're making the right determinations in the first place. And I'd be remiss, just let me correct one factual issue. I said it was a 14% overturn rate overall. That is in Part A, since a lot of our the issues you identified were in Part A.
And Mr. Chairman, if I can, so the answer is, however, we don't know how many providers are unable to appeal, and there's no test to determine. I mean, you have one side of the data equation, and I'm not sure that that's an accurate representation as a result. So I appreciate that you're looking at these tests, and I'll yield back, Mr. Chairman, but I'd like to explore that further.
Be great. We will in the second round on that. Before I yield to Mr. Gosar, let me just make one quick statement to Dr. Agrawal as well. You mentioned that there is the incentive for RACs to be able to limit that because they lose their contingency fee if they lose on appeal. The problem with that is a fishing illustration. Let me give you an Oklahoma illustration. If you're fishing, you can put one hook in the water or you can put 5 hooks in the water. And you may only catch one fish, but you're going to catch more often. And if a RAC decides they're going to try to just grab 20 different cases and they hope that they win 10 of them, that's better than just grabbing 10 of them. And if it's close, go ahead and just grab that file and keep moving from there, and we may win it, we may not win it. That's helpful to the RAC in their contingency fee. That's definitely not help to the provider to then have to go through all the process, and we can talk about that more in just a little bit. With that, I recognize Dr. Gosar.
Thank you very much, Mr. Chairman. While you were on that frame of thought, do you have any differentiation in your facts in regards to small providers, large providers, and overturn rates?
I don't think the data differentiates in terms of the appeals data. I'm not aware of data that differentiates between small and large. I think the point I made earlier is that we do have different requirements of the contractors when they look to audit a smaller provider versus a larger one. There's different medical record request requirements to make sure, again, to try to limit that burden that is being placed, especially on the smaller provider.
It would be very interesting to know, particularly I represent rural Arizona, and so I would like to see some type of a movement to try to make that accountable. When you said an overturn rate with Part A, what about Part B?
I'm actually not aware of, I don't have the figure in front of me. We can actually connect with your office if that's okay to get you a Part B overturn rate.
I think that's very, very important just because most of those Part B aspects are actually institutions, not individual providers. Would you agree?
I think the part, let me just make sure I heard you correct, sir, that I believe the Part A claims are the ones that tend to be more institutional hospitals, yeah. And then the Part B claims can tend to be individual providers or groups of providers.
Okay. Ms. King, from your oversight aspect, do you see maybe a change that you would recommend for methodology instead of looking at the provider as being guilty in an aspect, kind of an atmosphere like that? Do you see a better way of handling this?
I don't actually think that the post-payment review starts off with the provider is guilty. I think it's not a criminal matter. It's a matter of either an overpayment or an underpayment. And I do think that CMS has a responsibility as stewards of the trust funds to make sure that claims are paid properly. And as part of that, I think they need to do as much as they can effectively on the prepayment side, but I also think that they need to look at the postpayment side. That being said, we have found some instances in which the requirements are posing administrative burdens on providers, and we have recommended that CMS reduce not the requirements, but the differences across contractors so that providers have a better understanding of what they're required to do.
From the standpoint of that process, Dr. Agarwal, is there a way that we could actually identify maybe frequent flyers? Do we have a frequent flyer list? I mean, state boards kind of do this. I mean, we're kind of replicating something that state boards do.
Well, I think we take a different approach. So you know, the spectrum of program integrity is long, and there are folks on one side that are totally legitimate providers that are trying to abide by our rules, that are honest, and they're the vast majority of providers. On the other side, a much smaller subset are potential criminals or people that are perhaps trying to rob the program. So we do take, you know, I would argue that the various approaches that we have to overseeing this program integrity issues do try to take into account where our risk really lies. And I think part of why we can take an audit-based or post-pay approach for the vast majority of providers is because they are legitimate and an audit is a reasonable approach for them. We do take a much more kind of risk-based approach on the fraud side that really can ratchet up the intensity of how we look at a provider based on findings from audits. I think that's really appropriate for providers that are pushing the line, potentially even committing, you know, criminal activities. We try, on the other side of the house, to take a much more fact-based approach. We look at issues that are big national issues where we know that there are improper payments, and then, you know, we'll do deeper analyses to determine which providers to look at. But it tends to be focused on where our improper payments are occurring. It isn't sort of a ratcheting up on a single provider.
Yeah, but wouldn't it be more efficient in regards to looking at the profile, having some type of a profiling aspect? You know, in state boards, I mean, you have a list of most of your problems are with 10% of the population.
Right, and I think the comparison to state boards, I mean, I would just remind you that state boards are often dealing with the most difficult of cases. They're the ones on the right side of the house where, you know, these are providers that are committing potentially criminal or negligent activities. So they are dealing with probably the worst or the worst actors. Again, we do that with a similar set of actors. I think what we are looking at perhaps, and again, to try to decrease the potential burden from these audits, is not ratcheting up, but perhaps looking at solutions that might ratchet down. So as providers get audited and it turns out that their claims are substantiated, that there are not a lot of errors, we can perhaps audit them less. That's a solution that, for example, we're looking into to see if we can implement.
Gotcha. Thank you, Mr. Chairman.
Can I just follow up on that as well? As of when? When will that occur? Because that is one of the recommendations that hovers out there. How does someone prove, basically, I'm a good actor, and they don't get someone constantly coming in to check them all the time?
I think there are a number of solutions that we're looking at. As I think somebody pointed out earlier, the RAC program is currently in a pause state where we are actually working on the next round of procurements. As part of that procurement activities, we are looking at the statement of work, taking into account a lot of opinions and input that we've gotten from stakeholders, including providers, and are trying to solution how RACs can still do their job, still meet our obligations, but try to decrease that burden. That's one of many solutions we're considering.
Okay. Let me come back. When?
I couldn't promise you an exact date.
Is that something that for providers they can think about for next year? Is that 2 years? Is that 10 years from now?
Well, I think we are working on the procurement now, and we hope to complete it this summer in the next few months. And so it'll be, I think it remains to be seen if that's a change that can be pursued in the near term or potentially.
So that change is still under discussion. That's not a definite. That's under discussion at this point to try to figure out. I've got a good actor there, as Dr. Gosar mentioned.
Yeah, it's one of many solutions that we're looking at. Again, we've heard a lot of input from the provider community, and we are trying to take action where we can.
All right, we'll come back to that. Mr. Horsford.
Thank you very much, Mr. Chairman. Listening this morning, it gets a little frustrating when we're up here because it seems like despite the fact that we all come from different communities and are sharing very clear examples of why the approach that's being taken isn't working, we continue to get pushback and basically reiterating the same points without any clear determination of when things will improve. And on behalf of the constituents I represent in Nevada, Medicare is vitally important to their quality of life. I'm talking about the beneficiaries here. And when someone who is Medicare eligible can't see an OBGYN in my community because there are no providers who will accept them because of issues ranging from the reimbursement rate to the delay in being paid for services rendered to other compliance issues. It makes me want to know what can we do now in the short term to be able to move this forward. You know, Medicare is a bedrock of our programs. People rely on these services. We have providers who about a third or more of their patients are typically Medicare covered. And as my colleague, Ms. Grisham, explained, it also typically includes Medicaid or other pay sources as well. And so when you layer that burden on the provider, it's tough to provide services. That's what we're hearing. So after speaking to several stakeholders in Nevada, particularly hospitals and medical providers all around the Las Vegas Valley, and I also include some of the rural counties in Nevada, which are woefully underserved by enough providers. The accountability of the Recovery Audit Contractor Program seems questionable at best. And I don't understand how you continue something that hasn't even been properly evaluated. While these programs have a noteworthy mission of seeking out improper payments of Medicare services, it seems there are potentially perverse incentives to these RACs. In 2010, the RAC program was expanded to all 50 states and made permanent. Now, again, I don't know how you start something, don't evaluate it, and then expand it to 50 states, first of all. In 2013, over 192,000 claims were filed by these auditors to the Office of Medicare Hearings and Appeals, contributing to a backlog of over 357,000 claims. The Recovery Audit Contractor Program, as I said, may have been well-intentioned, but there have been unintended consequences. So, Acting Deputy Inspector Ritchie, in your testimony, you include a long list of policy recommendations for CMS to address. You reported that 72% of denied hospital claims at the third level of adjudication are overturned, ultimately in favor of the hospitals. What recommendations have you offered CMS and this committee to address the concerns that RACs are, no pun intended, dramatically racking up the number of claims backlog?
Thanks. I think first we've offered recommendations both in the RAC area and in the appeals area. I think it's important, while they're so intertwined, to consider those separate in some ways too. In our RAC work, it was all of the work that we're talking about was before this current backlog. But we've seen things that we still think are relevant in the RAC work. We did see in 2010 and 2011 that they were helping fill a need. As I mentioned in my testimony, we need to make appropriate payments, and when inappropriate payments are made, they need to be recovered. They did recover $1.3 billion in 2010 and 11, and 6% of them were appealed. And when they're appealed, there's a very high overturn rate, so clearly something needs to be done. I'd point to our ALJ work for the recommendations I'd push to the most, because for the system to really work and where the backlog is, we think the biggest recommendation that we had is just Medicare policies are not clear. And I think, all fraud is certainly improper payments, but all improper payments are not fraud. And most of these providers are not committing fraud. They just don't understand a complex system, and they're trying to submit claims. It's complicated. Then we saw in our ALJ work that 56% of the ALJs overturned, 20% of the quicks at the prior level overturned. And a lot of that was just due to different interpretations of the policies, differences that they were doing there. So our biggest—
So are there a set of recommendations dealing with the Medicare policies?
Yeah, in our recommendations, because there's so many of it, it's mainly to clarify, select the policies that need to be clarified, clarify those, and then educate people on the policies to create less overpayments, less appeals in the process. For instance, in my written testimony, I talk about our home health work. We found with the recent face-to-face requirement that if a physician is certifying that you're eligible for home health, they have to have a face-to-face encounter. We found $2 billion in improper payments in 2011 and 12, and a third of the claims didn't meet the requirement. Now, we don't think a third of the claims were fraudulent. It's because these are complex policies. As people get more used to them, it'll probably go down. But to educate people on the policies, make them more clear, we think is really a key to keeping the appeals backlog lower.
Okay, I know my time is up for this round, so I'll come back to additional questions.
I'd like to recognize the Chairman of the full committee, Chairman Issa.
Thank you, Mr. Chairman, and thank you for holding this important hearing. The gentleman from Nevada and I don't always agree, but every once in a while there's a nuance of agreement from this extreme to that extreme of the dais. And this is one where I think the entire committee is frustrated, and Chairman Lankford's work on this, in addition to ENC, I think really shows how bad things are. And let me just give you two questions, and then we'll go into comments. Dr. Aguilar, let me just ask you, and for the IG, Mr. Ritchie, New York State owes us $15 billion in overpayments. They flat billed more than the CMS maximum for Medicaid, and we held hearings on that more than a year ago. What have you done to get $15 billion back? Well, in fact, you're sending out hordes of people to harass doctors with a less than stellar success rate of success and accuracy in the audits. What have you done to get back from a State that knowingly billed far greater than the rate? And it's $15 billion. It's 10 years' worth of your recovery. Any answers?
So that is an area that we are looking at now.
You're looking at it. $15 billion, and you're looking at it.
At the request of the committee, we are currently taking on an evaluation of New York State. We're waiting to get the findings and then release the results, after which time I think we can have a conversation about how to proceed.
The newspapers make it abundantly aware. The numbers speak for itself because they're hard numbers of what was sent out versus the maximum allowed in law, and you're looking at it more than a year later.
Sir, I think these evaluations do take time. They are rigorous. They're designed to be rigorous.
They do. Do you know how many doctors have had to stop their practices and answer nothing but questions because you take their money and then they try to get it back? Isn't that correct?
I wouldn't characterize it as stopping their practices during the—
No, I'm telling you the doctors in some cases have to stop their practices because the audits for small practitioners are incredible detail, and they don't get their money back until they prove their innocence through the process. So let me go through this again. You have the right to stop payments to New York State based on a good faith belief they got over $15 billion. And then they can spend legions of time trying to argue why they should get to keep far more than they were supposed to receive, couldn't you?
I'd have to look into whether or not we have that authority, sir.
Well, why don't you look into it, Doctor? And while you're looking into it, pursuant to congressional action under the Small Business Jobs Act, you owe the ENC, and subsequently we get a copy of it, you owe a report, a second-year report on predictive modeling, don't you?
Yes, we do.
And you voted since October.
I believe the report has actually been due since earlier this year, but I take your point.
No, you don't take my point. We just did away with a whole bunch of reports by congressional action, ran it through the House. It's over. I think the Senate may have already acted on it, because we do ask for reports we don't always need. But they didn't just ask for this report. We ordered the executive branch to deliver it. It is extremely important because the kinds of things that the gentleman from Nevada were talking about, auditors going out half you-know-what, being wrong, and on appeal often being dramatically overturned even to $0 in some cases after physicians and clinics go through a great process, much of that would go away if your predictive modeling went and looked for the fraud where it was most likely to occur. Mr. Ritchie, are you concerned that Chase Manhattan can see your credit card perhaps being misused and calls you, but the organization that you're auditing has no such capability?
Yeah, that's definitely a concern. I mean, we do think that the fraud prevention system has taken steps and shows promise. I know, tying to the other question with our RAC work, one of the things that CMS does when they look at the RAC audits is they identify vulnerabilities. If there's cumulative issues over 500,000, and they need to address those vulnerabilities and then assess them. So one of our recommendations was to fully do that, because we had found, once they identify and recover overpayments, you need to set up the safeguards to prevent them from occurring in the future so you don't have this problem.
And has the IG looked into the excess payments requested by and given to the State of New York that this committee earlier had, as to whether or not any criminal charges could be brought?
I'm not aware of that. I don't believe we've looked at criminal charges. I do know that we have.
But they knowingly overcharged more than the maximum, and then they cross-funded that payment to other services not even covered by CMS in many cases. So the question is it worth taking a look to see whether or not the threat of criminal just might get New York to return $15 billion in excess payments, 10 times what your audits that we're talking about here today in part are revealing?
Personally, yes, I think it's worth it. I'm not the enforcement person, but my office and audit, we've done a whole series of audits in New York that we've shared with the committee, and I can go back to the office and talk to our investigators about this and our counsel and look into it.
Okay. Well, Mr. Chairman, I appreciate you giving me a little extra time. I will say that I'm deeply concerned that reports required by Congress that ultimately are necessary in order to improve the system are clearly done, but are being held back so they can be sort of looked at again and again. This is the politicking of releases. And I would only suggest to the Chairman that we have the authority to compel the work documents if we need to, if that report doesn't come in a timely fashion from here on. And I yield back.
Dr. Agarwal, just before I yield, this was a pending question from the Chairman. When will that report come? We know it's months late. When?
So, as you know, the Small Business Jobs Act requires us to not only produce a report, but to have the results certified by OIG. We are in the process of working with the OIG to achieve that certification. That is taking some time. I hope to release it as soon as we can.
That doesn't answer a when, does it?
I cannot give you a specific time frame right now.
Can you give me, is it a week or is it a decade?
It's less than a decade, sir.
How
what
much
I can
less?
tell you, what I think is
this is a report all of us want. It matters to all of us because it deals with what we're all dealing with providers, trying to shift us to where we all want to go.
Right.
When? Is it a month? Is it 2 months? This is a simple question from the Chairman. When?
I cannot give you a specific date. However, I think what's important for the committee and for the American people and public transparency is that we not only release a report, but that we release it with certification from the IG so that people can trust the numbers and base future decisions upon a certified report. I think the importance of that is clear, so we are working to achieving that.
Mr. Chairman, only because the doctor did say public transparency would be releasing all of the work documents that show the reason for the delay, the discussion, the political correspondence, the loop to the White House that occurs on each of these reports. I rather doubt we'll get that transparency.
We want to have that.
Mr. Chairman, will you yield?
I would yield.
Doctor, it's a pretty simple question. If you can't give us a precise date, is it 3 months? Is it 6 months? and what's holding it up?
As I mentioned, again, we are working closely with the Office of Inspector General, as required in the law, to try to achieve certification for this report. I think the importance of that is very clear, so that people can not only get a report, but can trust the numbers that are in the report.
We're not stupid up here. We understand when people are trying not to answer a question. So if you would, be kind enough to answer the question. Is it 3 months away? Is it 6 months away? And what's holding it up?
I cannot give you a specific date. The reason I cannot is because it's a process that is being worked in collaboration between CMS and the Office of Inspector General.
Well, you can give us a precise date. You need to maybe ask someone else, but we expect to know. We have the right to know. If there's a problem holding it up, we have a right to know what's holding it up.
It isn't an issue of holding up the report, Congressman.
So you have a draft report that is complete. Is it just being agreed to by various parties that then makes it available to be released?
Again, I think our
No, just answer that question.
Our objective
answer the question.
We are working with.
Is the draft complete?
There is a draft report that utilizes a methodology to arrive at savings numbers that the Office of Inspector General is reviewing or is in the process of reviewing. We hope to be able to release that report in the next month or two. I cannot be more specific than that because it does depend.
That's helpful. That's a lot better than earlier.
Mrs. Duckworth.
Thank you, Mr. Chairman. I'd like to follow up a little bit on what the Chairman of the Full Committee, Mr. Issa, was talking about, these RAC audits. I agree that combating Medicare waste and fraud is a critical goal. In fact, there are studies that show that as much as $50 billion are wasted each year due to fraud, waste, and abuse in both Medicare and Medicaid. We need to go after that. But it's also become clear to me that the well-intentioned efforts of CMS to accomplish that goal are not working and are badly in need of reform. I want to talk specifically about how these audits, these RAC audits, affect the orthotic and prosthetic industry and the patients that they serve. I have personally heard from providers all over the country, many of whom are small businesses, how they're being targeted by overzealous and misdirected audits that are threatening to put them out of business. They're having to wait years and carry hundreds of thousands of dollars on the books that they're not getting paid for, and these businesses simply cannot survive this. Taken collectively, the stain on the industry undermines access to critical services for patients who have suffered from limb loss or limb impairment. Oftentimes, these businesses are the only providers of prosthetics and orthotics in their local area, which now means that the patients cannot get access and must go without the limbs and medical equipment they need for their lives. The volume of audits has led to a huge backlog in appeals for providers who feel that they have been wrongly denied payment for very legitimate services. I'm particularly concerned that CMS has chosen to deal with this backlog by suspending for 2 years the ability of providers to appeal decisions at the administrative law judge level. With ALJ siding fully with providers in over half of all decisions, and in a context of increasingly aggressive CMS audits, it's simply unacceptable to deal with the problem by denying the provider's due process. So you're continuing the audits, you're taking these people's money by not paying them and saying now you have no right of appeal. You're going to have to wait for over 2 years. Businesses, that's not the way business works, and you're going to drive these hardworking Americans, these small business owners, out of business, and you're going to leave all of their patients out there without the limbs and the equipment that they need to in order to live their lives. At the public hearing on this issue, the Chief Administrative Law Judge Griswold gave an explanation of how the Office of the Medicare Hearings and Appeals of their position, but really offered no short-term remedies that would restore the right of a timely due process to providers. If you are going to suspend the hearing by 2 years, then suspend the RAC audits for 2 years. Give them their money back and collect it 2 years later. It seems blatantly unfair and un-American to take these folks' money and not give them the right to due process. Mr. Agrawal, does CMS have any plans to restore fairness to the system for our providers?
So just to clarify at the outset, the third level of appeals, or the administrative law judge level, is outside of the jurisdiction and oversight of CMS. It's overseen by OMHA. What we have direct oversight over is the first 2 levels of appeal.
Okay.
everybody is afforded, any overdetermination, whether by a MAC, RAC, or other contractor, providers are afforded the opportunity to use that appeals process as part of their oversight of us to make sure that the audits are being conducted appropriately and the right determinations are being arrived at.
What's the backlog at the first 2 levels? How long are they waiting for to get into the appeal process and getting a result?
At the first 2 levels, the second of which is an independent level of appeal or oversight, the OIG has actually published a report that shows that there is no substantial backlog at the first 2 levels of appeal. The backlog issue really arrives later. And on average, we are within the timeframes that are required of us. I would say, in addition, with respect to the orthotics and prosthetics issue that you brought up earlier, this is clearly an important area. And if there are, issues of access to care with respect to specific beneficiaries or companies, I'm happy to work with you on that. That is a priority for us. So
excellent. I will have the orthotics and prosthetic industry come in and sit down and talk with you. Let me ask this. So what you're telling me is the 3rd level of appeals is holding everything up, and they've suspended for 2 years the right to due process. And even though this is being caused by the RAC audits that CMS is continuing to conduct, it's not your fault, it's someone else's fault, but you're still going to shove more people into the system who now have no access to this. And I mean, it's kind of convenient, don't you think, that you're pushing people into the system with these aggressive RAC audits, but on the other hand, you're saying it's not our fault that they can't get through the 3rd level. What are you doing to work with the administrative law judges to fix the delay in the appeal process?
Sure. So we've taken a number of approaches to ensure that, number one, the audits are being conducted appropriately, and then wherever we can, to help address appeals issues. We are actively working with OMHA on their backlog and trying to arrive at solutions in conjunction with them. I think on the front end, where we have, again, more direct oversight and authority, we've implemented certain strategies to ensure that the audits are being conducted correctly, that they're being achieved with high accuracy. As just one example in the RAC program, we do have a validation contractor that looks behind the RACs to make sure the RACs are following CMS requirements, CMS payment rules, CMS guidelines, and all of the RACs have achieved a well above 90% accuracy rate of their findings. I think that goes a long way to ensuring that the RAC activities are, in fact, being monitored, and while providers will always have the opportunity and should have the opportunity to appeal, we want to make sure that the initial determination is accurate.
I don't think it's accurate when over 50% are being overturned on appeal. I think that that's a pretty high failure rate of your RAC audits. I'm out of time, Mr. Chairman.
I'd like to ask unanimous consent. There's a statement that's been sent to us by the American Orthotic and Prosthetic Association. I'd like to ask unanimous consent to be entered in the record without objection. Mr. Meadows.
I want to follow up on that because you're acting like you have nothing to do with this backlog. And I think that that's an unfair characterization. Do you not agree? You have nothing to do with the backlog.
I think, clearly that providers would not have a lot to appeal if we didn't enforce our rules and deny certain payments from being.
Well, let's look at this. The Inspector General's report, and they said that the overturn rate at the appellate level is anywhere between 50, depending on how you read it, between 56 to 76%, according to the OIG. And so those don't get to that adjudication level without you doing something. Isn't that correct?
We, clearly do. I think we have a number of steps that
you have to review them first before they get here.
And
then they get overturned between 56 to 76% of the time, according to this OIG report in 2010.
And not
do you
only
disagree with that?
No, sir. Not only do we.
So you do have part of the reason why we have a backlog, because it's on the front end. You're just denying claims and denying claims. I've talked to physicians. I've talked to hospitals. I've talked to health care providers. And you know what? They say the first fair hearing they get is at the administrative law side of things, and that what happens is you guys are just denying them, and you're saying it's tough. You have to pay it and wait for your turn in the queue to get the hearing. Do you think that's fair?
I don't think that's a correct characterization.
Okay. All right. Well, let me ask you another question. This comes from the HHS Gov website, and y'all changed that within the last 30 days. It's been changed. And what this says is that the average processing time for appeals are decided in 356 days. Would you agree with that? for fiscal year 2014.
Again, sir, if you're talking about the third level of appeal or the ALJ level, I couldn't comment on their data.
Well, this is on your site. Fiscal year 2014, the average appeals time is 356 days. Would you agree with that for fiscal year 2014?
I think if that's what the data shows, then that's clearly what it shows. I think our number.
So how would we know that? Fiscal year 2014 hasn't even ended yet. It doesn't end until September 30th. So how would you know this?
Sir, I'm not exactly sure what data you're looking at or how it reflects
It's on your
CMS's
site. I'll be
activities.
glad. We can give you a copy of it. If somebody in your office knows, because you've changed it within the 30 days, because what you were saying is that they were not being assigned for 28, and I'll give you 28 months that they weren't being assigned, and that's been changed. Who changed it?
I think all of the issues that you're describing, if hopefully this is accurate, is that they are really the third level of appeal or ALJ levels sort of issues. What I stated earlier is that we have oversight of the first two levels of appeals, and we are abiding by timelines required in those appeals.
Let me tell you, moms and dads back home, they could care less about the internal divisions. They see it as all part of CMS. They see it as one of the same. They see it as the government. And so here we are for the budget request that we've got, that says the backlog is going to reach 1 million. At what point does it become a crisis? At what point? When does it become a crisis? When do you start putting companies out of business, because you already are? When does it become a crisis that you're willing to do something about? This is your document. 1 million backlog by the end of this year. So is that a crisis?
Well, sir, if there are individual companies that are being put out of business by these audits, we do have flexibility in how we
But you don't. I've already called on behalf of some of my constituents, you know, and that would be a great response, but it's not true. Because you know what? I've dealt with Jonathan Blum. I've called to make sure that Kathleen Sebelius knew about it. I've called the White House. And you know what? You say too bad. So what do I tell the moms and dads who are going to lose their job because they do not get a fair hearing? What do we tell them?
Well, sir, we are able to do what we are authorized to do. So whether it's an alternative payment arrangement or something else working with a provider,
all right,
we can
so
do
you've
what
got
we have.
5 years for an alternative payment arrangement. I know this stuff. I've been studying it for the last 6 months, 5 years. So if the backlog is 10 years, what do they do? What do? They just pay it? Because right now, at 1 million people, at 1 million appeals, your rate, the best rate that we've had from the adjudicators is $79,000 a year. And even with your budget increase, that would still be a 10-year delay. That's a taking in my book. Would you wait for 10 years for your salary?
So
yes or no?
we do whatever we are authorized to do in terms of working with providers to try to make the system less burdensome.
All right,
for
so
them.
how do we
can
fix it?
stretch out payments. We can change things in individual cases. But again, we cannot overstep the authority that has been granted to us by Congress.
But something changed. Something changed, because you know what? The audits went from 1,500 a week to 15,000 a week. So what did you change? Because, I mean, it's in your documents. I'll be glad to give you that, too. Actually, it's worse than that. They said it went from 1,200 and change a week to 15,000 appeals a week. What did you change?
So again, I think it's important to level set on this. It is our obligation to audit. We have improper payments that you've heard about from the other witnesses, that you've heard about from the rest of the committee. It is our obligation to go after those improper payments, to try to reduce the rate and make recoveries where possible, or you know, where they should be made. That is an obligation created in law. And to also level set, sir, on the amount of auditing that we do, we audit far less than 1% of all claims that we receive. In fact, all of the overpayment determinations made by RACs in the latest available data to the public account for less than 1 day of claims that come to the Medicare program.
All right. My time has expired. I would like one answer to this. The law says that they need a decision in 90 days. Is that law being violated, and who makes the choice on what laws we enforce and what laws we ignore? The law says 90 days.
I cannot comment on the processes that are outside of the jurisdiction of CMS.
But this is in your jurisdiction. I'll be glad to give you a copy.
No, sir, that is at OMHA.
No, this actually talks about qualified independent contractors, which is under yours, and then the ALJ is after that, 90 days after that.
Great. So as far as the second level of appeal at the qualified independent contractor level, there is recent reporting from the OIG that shows that we are remaining on track as far as the expectations of how long it takes to go through that appeal.
Jonathan Blum said you changed something in 2012. What did you change?
So I was not part of that conversation.
Do you know of any changes that happened in 2000? I'm out of time. I yield back. I apologize, Mr. Chairman.
We'll come back around in a second round. I'd like unanimous consent to have Ranking Member Spears' opening statement be entered into the record. Without objection, Ms. Spear, you're recognized.
Mr. Chairman, thank you, and I apologize for my late arrival. We had a memorial service at Arlington Cemetery for service women, and I felt compelled to be there, so I apologize for not being here for your opening statements. Let me say at the outset, I've had local hospitals that have gotten embroiled in the RAC situation. I have a hospital that's teetering on bankruptcy right now, and the RAC experience has exacerbated it. But I also think it's really important for those of us who sit on this committee to recognize that we have an obligation beyond just beating up on those who come before us like this, to recognize that if we want to fix the backlog, we've got to pay for it. There's a backlog because in 2007, RAC claims amounted to 20,000. Today, that number is 192,000 a year. That's 10 times what it was in 2007, and we have not added one single person to respond to those claims. So if we want to deal with this backlog, if we want to erase it, we've got to recognize that you cannot expect people to do 10 times the work with the same number of work hours. Now, let me start with Mr. Ritchie, if I could. You've had a pretty remarkable run in terms of the efforts by the Healthcare Fraud and Abuse Program, which resulted in $4.3 billion in recoveries to the Treasury in 2013. That represents an 8-to-1 return. Is that the highest level of recovery to date, Mr. Ritchie?
Yes, that is.
And how was that achieved?
Well, we partner with our other partners in enforcement in the HCFAC program to fight fraud, waste, and abuse through investigations, through audits, through the evaluations that we've done. The recoveries that were reported in fiscal 13 were record recoveries.
Now, I think in your testimony you referenced that sequestration will result in a 20% reduction in OIG's Medicare and Medicaid oversight capabilities. Is that correct?
Unfortunately, yes.
So what does that mean in terms of what you're going to do and what we're going to see in terms of waste, fraud, and abuse being properly handled?
For our office, it's not good. It means less investigations, less audits, less evaluations. I mean, I'm not the budget expert, but I certainly live this every day. I work in our audit office, and I'm acting in charge of our evaluation office. At this point, between 2012 and 2014, Medicare and Medicaid outlays went up 20%, and during that same time, my office has had to reduce our focus on Medicare and Medicaid by 20%. It's really challenging given we have a $50 billion improper payment, a 10% error rate, that we're dealing with this, that it means less auditors, investigators, evaluators on the ground to handle this. I've been working in IG for 27 years, and I can just tell you personally, I mean, I've never quite felt as challenged looking ahead to see with the growing programs and growing responsibility how we go about doing this.
So should we just roll out a red carpet for the fraudsters in this country?
I would certainly hope not. I mean, in our office, we try to do a risk assessment to pick the best topics. You know, we make our budget request, and for us personally, I mean, the best thing that could happen would be to fully fund our budget request to try to get us back on target. It's definitely decreased. We've gone down by 200 FTEs, full-time employees over that time. You know, we've had to stop evaluations and audits. We've had to stop following up on investigation leads.
So is it safe to say that because of the reduction, there are investigations that haven't moved forward that probably would have resulted in savings to the taxpayers in this country?
Yeah, absolutely. I mean, investigations and audits both, that we have to make tough choices every day for what we start and what we can't start. I mean, it's been a very difficult time in sort of looking at this. I think you're making tough choices with things that look very good. You do a risk assessment and feel like there's so much to look at, but you only have so many resources, and those resources are declining. I mean, we've had a hiring freeze for 2 years, and people have left through buyouts, so we've just been consistently reducing.
So give us an example of the kind of case that you had to let drop by the wayside. I mean, do you drop cases that are just so big that it would take so many resources? So are the big fraudsters getting away with it more than the little fraudsters?
Well, I'm not. In our audit and evaluation offices, so I'm not there. I do know that our investigation office told me that they've closed 2,200 investigative complaints since 2012. I think it's a mix. I mean, we try to do the best risk assessment we can and put resources on the biggest cases, but certainly we can't afford to do all those. I know our strike force activities have been a big success. In our strike force cities, we've had a reduction in resources, so it's been across the board in every aspect of the IG's enforcement. All
right, my time's expired. I'll follow up with the second round.
Mr. Chaffetz.
I thank the Chairman. And Ms. King, I appreciate this GAO report that you put out. I want to go to the first complete page. This is the second paragraph, the latter half of it. I'll read it to catch everybody up. For example, CMS has hired contractors to determine whether providers and suppliers have valid licenses, meet certain Medicare standards, and are at legitimate locations. CMS has also recently contracted for fingerprint-based criminal history checks of providers and suppliers it has identified as high risk. However, CMS has not implemented other screening actions authorized by the Affordable Care Act that could further strengthen provider enrollment. Can you help enlighten me where you think they have not implemented other actions to strengthen the process?
Yes, I think there are a few things that we point out. One is in relation to surety bonds, establishing a regulation regarding surety bonds for certain types of providers. One is in not publishing a regulation that has to do with disclosure of past actions that have been taken against providers, such as payment suspensions.
So, Doctor, why not do that?
I think these are great ideas. When we have really appreciated, the agency has appreciated working with GAO on ferreting out where our vulnerabilities and weaknesses are and trying to do something about them. There's nothing conceptually wrong with these recommendations. We continue to have the conversations. We have to prioritize changes. Yeah,
I'm just wondering why you haven't done it. I mean, we're trying to get rid of the waste, fraud, and abuse, right? And it's authorized by the law. Why haven't you done that?
Absolutely. It isn't, I think, a disagreement over the objectives. We have done a lot in the last couple of years to really, beef up our approach to provider enrollment and screening. Some of the stuff like fingerprinting is just coming online now. So, there are just bandwidth limitations in terms of what we can get to and how quickly based on resources, based on budget.
Is there a prioritized list or summary that you could share with the committee so we understand what you are prioritizing, what you're doing, what you're not doing?
Well, I think you're clearly seeing some of the priorities already occurring.
I know, but where do I find that? Is that something you can provide the committee?
I don't know that we have a list. I'm happy to have further conversations with you.
Can you create a list? We're trying to get some exposure, some transparency, which you say you're in favor of what you're doing or not doing. The GAO right at the front is saying you're not doing all that you could do. I'm sure you've got to make some choices. I want to understand what you have prioritized and what you're doing and not doing. Is that fair to put that on a piece of paper and share that with the Congress?
Well, I think perhaps it'd be useful to get your insights, and we can continue to have conversations with GAO on
Hey, you want me to run your agency? I'll run it for you. But GAO is making recommendations authorized by the law to do these things. I just want to see what you're doing and not doing. I'm not looking for a 700-page report. I'm looking for a couple-page summary to understand what you're implementing and what you're not. Sure. You got to have some sort of document.
Absolutely. We'll work on it.
I didn't expect to spend 5 minutes asking you if you had a prioritized list of what you're working on. Is that something you can or cannot provide the Congress?
Sure. We'll work with your office. We'll provide it.
When's a reasonable time to get that document? You come up with the date.
Can you give me a few weeks to do it?
Sure. Great. Pick a date.
How about a month? We'll get back to your office within the month.
The end of June, how's that?
Perfect.
Okay, thank you very much. One of the things that I've been working on that I'm worried about are these providers. Are we engaging and allowing people who have serious delinquent tax debt to be engaged in this process? This is a big government-wide problem I see, is that we have contractors out there who have serious delinquent tax debt. We yet hand them new additional contracts and allow them to continue to be involved and engaged. I would provide, and I don't expect you right off the top of your head to understand the answer to that question, but that's something else that I personally, and I think the committee would benefit from understanding. What are the policies that you have there? It should be a key indicator to me that if you're unable to pay your Federal taxes, why do we continue to contract and give you more and more business? The President's been supportive of this when he was Senator Obama. I think this is a very bipartisan thing. This committee has dealt with a bill very specific to that. If you could also provide me information about what you do with that, and the answer may be we don't do anything with that. I would just like to know the answer to that question. Can we also shoot for the end of June that you give me that information? Is that fair?
Yeah, I think that's fair. But I think just to comment on that a little bit, we have, there's all kinds of information that we could conceivably collect from providers. I think the question often, that we have is what information can we collect that is actionable for us? So there are some clear, bright lines in the program. If you don't have the right license to practice medicine in the state in which you want to enroll, then you don't get to enroll in that state. There are certain other types of disqualifiers, like certain felony convictions. So I think conceptually it makes a lot of sense to include as much kind of risk assessment data and analysis as one could to look at providers. But again, I think we have to, there's really just a subset of those potential risks that push us over the line and allow us to take action. If a provider ends up on, the exclusion list or the do not pay list,
and I'm also worried about the
helpful.
contractors that you're engaging that are supposed to help ride herd on this, that are supposed to help you engage with these people. Those are some of the specifics that I would like to see as well. It's not just, I'm not talking about the providers as much as I am the contractors that you're contracting with in order to make these things happen. Thank you, Chairman. Yield back.
Thank you. We're going to open this up for the second round for questioning. During this questioning time, there's full interaction on the dais. You can jump in at any time. There's no clock running this time period if you have interaction. Also, for our witnesses, if you have specific things that you want to get into the conversation, you're free to be able to initiate the topics in the conversation as well to make sure that you're clear. Our goal of this conversation is to make sure that we bring all the issues out, find the areas that need to be resolved, and what's the timeline for resolution on those things. So you're free to be able to bring issues up as well to make sure we have clarity on this. I want to reaffirm again. Let me take first crack at a few things here. I want to reaffirm again. This panel, myself included, is committed to how do we deal with fraud. There's $50 billion in unaccounted for money, possible overpayments and fraud. We affirm that we are pursuing that fraud. That is the taxpayer dollar, and it's essential, both for the solvency of the program long term and for the taxpayer themselves. So continue to do that. I think the frustration is the prepayment side of this. We all know that's the direction it should go, so we're not having to chase. That's why we want to know the report. We want to know what's happening at this point, how we get ahead of this in the days ahead, so we're not having to constantly go back to good providers and to say we're going to hold some of your dollars. Many of these providers may have a 2 or 3 or 4% profit rate, and for them to have a portion of their cases pulled and not paid for an indefinite period of time as they go through the appeals process is untenable to them. So I want you to hear from me and from us. We're not opposed to going after fraud. We're opposed to the methods it's currently and as it's being executed. There have been changes in the RAC audit process as CMS has learned its way through this. We're proposing additional changes in this to say what can we do to help expedite this process and to make sure when it's right and it is overturned in the appeals, they get their money faster and they have fewer people engaged. So let me run through a couple of these things again. We've gone through the revalidation process. Is that complete at this point for providers nationwide? We revalidated the providers. I know we've done fingerprinting, we've done background, they've had to re-enroll. Is that complete at this point? What stage is that in?
So the revalidation process that was initiated after the ACA puts us on a 5-year cycle. I believe the latest number is we have revalidated over 770,000 providers at this point. That puts us on track to be complete in time for the first cycle.
So 2 more years still left of that is what you're saying? Or?
I think that's about right, yes, if I'm remembering correctly.
Okay, then the prepayment pursuit of fraud, we have a report that's due to us. Obviously, we've already discussed that's coming in the next couple of months to give us the details and the progress on that. Then we move into the post-payment. Do you want to make any comments on the prepayment side?
Well, I think just that clearly the Affordable Care Act did provide us a lot of authorities to make changes on the prepayment front, such as payment suspensions, which we are now able to leverage against the worst actors. I think the only point that I'd make, Congressman, is to differentiate what we do when we are going after potential fraudsters, sort of criminals, the worst actors, from those providers, the vast majority that are perhaps producing waste or producing inefficiency in Medicare, not quite following our rules, but have the intention to follow our rules, are trying to actually do their best. I would just ask us to sort of keep this framework in mind because I think it sort of determines for us what tools we utilize so that they're not overly pejorative. I think payment suspension, for example, is a great tool for the worst actors. And though it is prepayment, it is not a great tool for legitimate actors because it essentially suspends all the payments that they'd be getting.
Right. Well, you're doing the same thing. It's the hammer that's down in the area. Even for the high-risk areas where there's a moratorium, some of those areas may have a deficiency of number of good companies that are actually providing. And as we continue to have more people entering into Medicare, there is a need for providers. And so even when a moratorium occurs on that's a pretty incredible hammer for that region to say there's lots of small businesses that won't start up during that time period that could be legitimate providers.
It is, I agree with you, sir. It is a notable piece of authority that we implemented with a lot of care and over time. So it took us years to go from having the authority in the ACA to actually implementing it for the first time. I would say the areas that we tried to address, both the geographies and then home health services as well as ambulance services, were areas that we knew there was a lot of market saturation. There was very little concern, though we have been looking at it continuously, about access to care issues. Home health and ambulance services in Texas and South Florida are areas of a lot of agreement with the Office of Inspector General, the Department of Justice, within CMS, with state Medicaid agencies, that there's just a lot of market saturation, sort of 3 to 5 times the number of providers than on average areas. So while access to care is clearly something we care about and we are looking at in real time to make sure the moratorium does not have negative impact on access, we are currently not seeing it in those areas.
Okay, let me come back. One last thing. I want to open this up. I don't want to take all the time on it. The 4 appeals that are total, I'd like to get just a timeline for everyone, the length of time. You said they're on schedule, so let's talk about appeal number 1. If someone has a problem with the RAC audit, appeal number 1 is to who and how long does that take?
Sure. So I believe the first level of appeals, providers have 120 days to file the appeal, and then there's a 60-day time limit for the decision to be achieved on the appeal.
Okay, so if they filed it right away, let's say, let's talk about your end of it. Their responsibility is their responsibility. So you have 60 days to respond, correct?
Correct.
Who is that that's responded to them? They're appealing to who?
I believe in almost all cases it's the MAC administrative contractor that would handle the first level.
So you've got the RAC folks make a decision, and then the MAC folks then are making the response on the appeal. Is that correct?
Correct.
Okay, so there's 60 days to respond. You're saying that's on time.
Yes.
They disagree with that. They come back in the second level. Who is that? How long does it take?
So the second level goes to the qualified administrative contractor, the QUIC. They have, again, 180 days to file the appeal, the provider does, and then we have 60 days to make a decision on the appeal.
And you're saying that is on time as well?
So I have average times that are below the 60-day mark, correct, sort of 53 and 54 days for most appeals.
And do you have the overturn rate on both of those?
It would depend on the specific audit. So is there a particular audit that you're referring to?
Yeah, either one, the first or the second level.
And RAC audits, sir?
RAC audits, yes, sir.
I'd have to look. These are not. So I think while I'm looking, let me just say I think the overall overturn rate for the RAC audits are, between parts A and B about 6% to 7%. That's in the latest data that is public.
But you're not talking through the ALJ process. You're just talking through the first two. That's what we're trying to figure. We're trying to get a cumulative number. We've yet to see a cumulative number.
No, I believe I believe that the 6% and 7% numbers are all the way through are ever overturned.
Okay, I'm trying to figure that out because the latest numbers we've seen on the ALJs are between 56 and 70-some-odd% of overturned just in that level.
Correct. So if I could perhaps explain it a bit. So the RACs, make determinations. I think the latest public data is roughly 1.6 million claims were found to contain some kind of overpayment. Providers then make a decision about whether or not to appeal those overpayment determinations. And basically at every level of appeal, as you go from 1, 2, and 3, the number of claims going to the next level comes down.
Right.
And the overturn rate might vary between the levels. So I'm not finding the number right away, but I think at the first 2 levels, oh, that's very helpful, thank you. So at the first 2 levels, we're seeing a 9% overturn rate for the RACs in specific.
Both of them or each one? 9% at the first level?
No, at the first level of appeal, 9% for Part A.
But you don't have Part B?
3%.
All right, then for the second level appeal?
At the second level for Part A, it's 14.9%.
So 15% basically. And then Part B?
0.5%. No, I'm sorry, I'm not sure if that's right. I don't have a called out. I have just the percentage of RAC appeals that actually make it to the second level, but I don't have the overturn rate for Part B on the second level.
Okay.
We can get that to you.
That one's unknown. And then they go to, after that, they've done 60 days in the first one, they've done 60 days in the second one, and then they disagree with that as well. And now we're headed to the ALJs, which is, as Mr. Meadows has commented on, now could take 10 years to get to that spot, depending on the perspective you get. Now, we've heard 28 months, but 28 months is pretty ambitious based on the number of people that are in the queue and the number that have typically been handled. I know you've said over and over again this is not your responsibility. We will visit with Chief LJs on this, but that's the next level. Then the fourth level is what after that? If they disagree with ALJs, then what?
There is another level that they can go to, which is, I think, at Federal District Court level.
Okay.
I'm sorry, it's the Departmental Appeals Board, and then after that, it's the Federal District Court.
So that's a fifth level?
Correct.
Okay, thank you. I want to get the context for everyone. Jump in at any point.
I guess my question is, so let's look at Part B DME only. What's the overturn rate for that?
It is.
Which would include orthopedic, some of the other stuff. Well, let me add. I've got a report here from your office prepared on April 2nd of 2014 that says that the overturn rate is about 52%. Is that correct? Is this report correct from your office? Would it be about 52% for DME overturn rate?
I think it really depends on what document and what level you're looking at. If you look at all DME claims, again, it's about 7.5% of all overpayment determinations end up in an overturn on appeal.
We're talking about on the appellate part. This is Office of Medicare Hearings and Appeals, their report. So those hearings and appeals, it says that the overturn rate is 52%, is either fully favorable or partially favorable. 24.87 was unfavorable. And so with that, it would indicate that the overturn rate is much higher than what you would indicate on DME.
There's a calculated overturn rate at each level. So what I just communicated about the first 2 levels just gives you the overturn rate for those levels.
Okay. I may not be real sophisticated, so I'm trying to figure out how does your report say 52% here and what you just testified said, where's the difference? Help me understand that.
So generally, as you go up in appeal, at the various levels of appeal, providers make a decision at each level about whether or not they're going to appeal to the next level. What we see are some general trends. So providers do tend to, the number of claims that are appealed at each level does tend to drop, and the overpayment or the overturn rate can increase. So at the 3rd level of appeal, at the ALJ level, the overturn rate is I can totally agree with what's on your piece of paper, that it probably does approach 50% for DME.
All right. So
but at lower levels of appeal, given that there's more claims that are appealed and fewer are decided in the provider's favor, the overturn rate is much lower.
That makes sense. So out of the 1 million in backlog that your budget request talked about, how many of those would you anticipate, based on this rate, are going to be overturned out of the 1 million backlogged appeals going to ALJ?
I think that's an individual case-to-case determination.
It is, but based
ALJ
on
makes.
historical evidence, how many of those would be overturned?
Sir, I can't really—
520,000 of them. I mean, based on these numbers, wouldn't that not be correct?
Based on those numbers.
Okay. So let me ask you one other question. Is the American Hospital Association, they have RAC facts. Per RAC track, which this is all Greek to me, 47% of hospital denials are appealed. And, quote, almost 70% of these appeals are overturned. Is that incorrect?
I can't really speak to their data, sir. What we know, we track the data, of course, very closely internally. Our numbers would not agree with that. If you look at the first level of appeal for Part A, we see about a 5% actual appeal rate that makes it to the first level.
Mr. Ritchie, if I could interject, there's a problem here. Why is it that if you've got enough money to go to the third appeal with the ALJ, if you could hold out that long, if you're not a single provider, if you're a big hospital, you could hold out. If you go to the ALJ, you've got a 60 to 70% chance of winning. Why wouldn't everyone just go to that appeal process if they can afford it? So the question I have is, why the discrepancy? What do you know about the ALJ system that allows for such huge swings in the determinations?
Okay. What we looked at, again, was prior to the backlog, but I think it's still relevant. We looked at the ALJs and at the time found a 56% overturn rate. This was 2010 data. For the prior level, the qualified independent contractor, there was a 20% overturn rate. The big differences that we saw, again, I've mentioned earlier the unclear Medicare policies we think are a trigger to a lot of this. At the ALJ level, we found that they tend to interpret them less strictly than at the prior level, at the quick level, because they're confusing, they're complex policies, and they're open to different interpretations. The other thing, at the quick level, it's more specialized. They have specific people looking only at Part A, specific people looking only at Part B, and they have clinicians reviewing that, whereas at the ALJ level, they're dealing with DME, Part A, Part B, everything that comes their way, and they're relying on documentation and testimony of the treating physician to make their decisions. So the process is different. We've also seen the case files are different. I mean, it's more of an administrative thing, but the things that they're maintaining and holding in the case files are different from level to level, and I think really creates some of the inefficiencies. For example, the ALJ level is still on paper. So the quick has everything electronic. They have to print it out and send it to the ALJ. They'll also get a paper file of the records maybe from the contractor sources, and they're trying to sort those two out. So some of our recommendations are definitely to clarify the Medicare policies, but also to create one system that's electronic.
So if I understand you correctly, at the quick level, they're very specialized. They know precisely what they're looking for, and they make their determination because they're trained to look for certain things, I guess. I guess that's part of what you're saying.
Correct. We didn't assess and make a judgment of which level is better. They're very different. But at the quick level, we've seen they have clinicians looking at it, and they're specific. If a complaint or appeal comes in specific to Part B, it's going to this. Quick, if it comes into Part A, it's going there. Whereas the ALJ, they've got everything. They've got
ALJs aren't clinicians, and
right.
They're using discretion in terms of interpreting the law.
In terms of interpreting the law, and then they're relying more on the treating physician's testimony and evidence, whereas at the quick level, they're relying more on their own clinicians to interpret the documentation.
But, oh, I'm sorry.
Go ahead.
If Congressman Spear will yield, I mean, it speaks to a couple of larger issues, and I want to get back at, what are the real overturn rates? Are we targeting correctly? And what can we do to improve this system so that we're not harming good providers, and which means that we're harming just the beneficiaries, going after fraudulent and wasteful behavior. Medicare is an incredibly complex system. And the reality is that if we don't start dealing up front with the Medicare complexities, we can chase this all day long and go from one extreme to the other, and we're going to find significant flaws in our ability to hold providers accountable and to support providers to do a better job. And what we haven't done in this conversation is I'm as concerned as anyone else about getting it wrong and overpayments. I'm also very concerned that your Part A providers are large providers. Your Part B providers, even though we might have, if you will, hotspots with the DME providers, that they can't afford to go through this process. So in that regard, your data is skewed for one group, and I'm not trying to vilify one group over another, but hospitals, large hospitals and large hospital groups can afford to wait a decade potentially. Smaller hospitals, as Congressman Spears identified, my colleague from California, cannot. I want to get back to maybe a couple of things. One, and then yield back. Can you give us some recommendations? You talked about the predictive modeling. You said we're identifying prescription practices that are clearly problematic. Is there a way to be targeting those areas? And is there a way to start targeting areas where we've got real issues with access? Because CMS has a responsibility to assure access. We're only doing one side of this here. We're eliminating potentially access, and no response about that.
So, I'm sorry, could you clarify recommendations for what?
Well, a couple. And the first is you identified in your testimony that there are areas that you've identified that we could start looking at much more directly and aren't. So we could do predictive modeling in terms of where folks commonly make mistakes and where we've got potential fraud. And two, you identified in that discussion, I don't know that it was tied to the predictive modeling per se, but that you've identified prescription practices that are clearly problematic. You said, I think, that you've got folks who are not prescribers, as an example, prescribing medications for beneficiaries. Why aren't we focused more in those areas? And then I wanted either Dr. Aggarwal or someone else to talk to me about what we're doing. If you've got hotspots for fraud, what are you doing to shore up mistakes so that we don't lose those providers by providing better education and support to those providers and creating in low access areas, frontier and rural states, what are you doing to assure you don't lose providers?
Okay, yeah, thanks for clarifying. We make those type of recommendations all the time. We have a series of reports that we call our questionable billing reports, several of which I've referred to in the testimony, finding questionable prescribers, questionable pharmacies, and questionable home health agencies in this. In all of those cases, we take the ones that we've identified that are extreme outliers based on a statistical test and give it to our investigations office to see if they want to further pursue, because these look severe. After that, we send them to CMS, and CMS will share with their contractors to take appropriate action. And we always recommend that they take the kind of questionable criteria that we have and implement. I know the fraud prevention system is starting to build some of that in. I think specific to the example that's mentioned in the testimony, and you mentioned on the prescribers, we saw $5 million in a year prescribed by people without authority to prescribe, massage therapists and things. Just yesterday, I have to look at this because it was late last night that I got it, but CMS actually issued or published a final rule that requires prescribers of Part D drugs to enroll in the Medicare fee-for-service program starting next June 1st of 2015. And this is going to allow CMS, the plans, and the Medicare program integrity contractors to verify that they actually have the authority to prescribe, because now they aren't, a massage therapist isn't billing Medicare, but they could write the prescription and for drugs that we found that were pretty severe. So that problem will be fixed based on this rule. So we are working with CMS to get some of the recommendations implemented, but I think it's a combination of doing things like that and implementing edits on a prepay basis to try to stop future improper payments.
I think what we're interested in, and I'm taking too long, but is to get that information to the committee so we know when, so that we can weigh in on how you're balancing these issues. And if the chairman doesn't mind, can we get something on the access? What are you doing to assure that small providers aren't discriminated even further in this process because of the size of the provider and the capacity of the provider? And have you thought about treating them differently, like we have tiered regulatory environments? What is your thought about making sure that access is protected?
Yeah, again, and I appreciate the question. That is an extremely important area for us. As far as tiering providers we do currently tier providers by size. We actually have medical record request limits specifically for the RAC contractors based on the size of the provider. I had also mentioned earlier a sort of future solution where we would ratchet down the number of reviews that a particular provider would face if the reviews are generally in their favor. In other words, they're basically following the rules. We are putting that solution into our RAC procurement process right now, so it will be part of the RACs going forward. I think, in addition to that, we do take, if there are overpayment determinations, we have a process for the provider to work with us and change the payment rate in order to still meet our requirements and still meet the requirements of the law, but to be able to afford them a longer opportunity so that we don't put providers out of business unnecessarily. I would also say, just on the front end, we are undertaking a lot of efforts to better educate providers about our specific payment policies. I think the DME face-to-face, or the home health agency face-to-face requirement is a good example of that, where the improper payment rate is very high. Because of this new requirement, providers need to be brought up to speed, and we are trying to do both specific audits that will look at that issue in order to educate both the home health agencies and the related prescribing providers. We also have just more general educational materials that providers can take advantage of. We also do try to be very transparent on the front end about what audits we're conducting. So once a new audit area is approved by CMS, that we put that information on a website that providers can look at, both big and small, to shore up their own self-audits, make sure that their compliance programs are working, and be prepared for audits in those areas. We hope that all of this helps to make the process more open.
And if it doesn't, what do you do to assure access?
Right. So I think, part of it is just we have an open door policy for providers. So we do want to hear about the shortcomings of these programs if there is an access issue or a burden issue.
And you don't think that providers, by and large, are going to be somewhat concerned about that open door policy, particularly in the context of audits and your efforts for fraud, waste, and abuse? Because when I was the Secretary of Health and the Secretary of Aging, I appreciate that mindset. We're here to help you. And by golly, no one believed that. And so I didn't really find that to be an environment that was very productive, particularly when somebody came to us, and in fact they were fraudulent, and we did our job. And so that certainly precluded that kind of a relationship. Can you please collect data for us, if you don't already, and provide it to the committee so that we can see what the percentage of small providers that are engaged in any level of these appeals versus the large providers?
Yeah, and I think we can do that, and I think it would be helpful to work out a kind of definition for small provider that we could focus on.
Yeah, and the last thing I would say, and I'm trying the patience of this committee, and I'm sure our witnesses, but I would, again, this committee wants you to ferret out fraud and to stop those bad actors and actually move those to criminal prosecutions and to prevent those folks from ever being able to engage in any of our healthcare systems or any government contracting ever again. I mean, that's serious about fraud. And we also want waste addressed. But I'm getting very concerned really about that access issue and that this is completely imbalanced. And I'd like you to consider and mitigate that by telling us what the risks are about changing the withholding of payments for the third level of appeal, taking into consideration, though, a new definition potentially or a refined definition for small providers, and to entertain that and maybe come back to us in writing about what that would look like. Thank you, Mr. Chairman.
Dr. Aguilar, the passion of which you've heard me today is not meant to be directed at you. It's a passion based on a number of people back in my district that potentially will lose their jobs. And I, for one, nor you, do I believe you, want them to lose their jobs because we have a system that is broken. When the chairman called this hearing, It was really a hearing about making sure that those who steal from seniors, because that's really what this is about, is fraud, those who steal from seniors get caught. But in the process, there are a lot of potentially innocent people that are getting caught up in that dragnet, that we have to find a better system to do that. I would ask you to submit to this committee, if you would, 2 legislative changes. If you're saying that your hands are tied, what are the legislative changes that you would support and recommend for this committee to perhaps have the chairman introduce, where we can fix it to make sure that we do go after waste, fraud, and abuse, but those that are innocent don't have to wait forever to get that innocent verdict, and in the meantime potentially go out of business. And I yield back to the chairman. I thank his patience and his foresight in having this particular hearing.
Let me ask a couple questions still to follow up on it, and it goes back to what Mr. Meadows was saying as well. Good actors we want to keep. Our seniors need to know, in my neighborhood, in my community, in my town, in my county, there is a good actor that's there. We have all talked to folks, I'm sure you are aware as well, on several areas. Last weekend, I had a gentleman that came to talk to me that wanted to tell me about the last year of his life because he was a durable medical equipment provider. He's now been put out of business. He was a good guy. He was willing to meet the price that was out there made publicly available in the competitive bidding process, but was not allowed to actually join into that because, as this group knows well, when the competitive bid was put out, if you didn't get the bid, you're out. And not just out, you can't join in even at the new low price. You're just out of business. He's one of those that came to me and said, I just want to tell you about the last year of my life when my family business went out of business and closed down a company and laid off employees, and here's what that looked like. I have individual providers that come to me and say, I had a group of files grabbed, not being paid for, that are going through the appeals process, and I'm fighting my way through that. And then as I'm fighting my way through that, I had another group of files that was grabbed, and now I'm fighting through those, and I'm in a different time period, and I'm not making payroll. I understand the comment of saying it's 1% or it's 2% of files. But if they start getting a set grabbed and then 60, 90 days later another set grabbed when they're still unresolved from the previous one, they're not going to make payroll for these smaller companies. So these are very real issues. We want Medicare providers to be there. We want our seniors to have access. We want individual health care folks to know if you take care of seniors, the bills will be paid. That certainty is disappearing at this point. And that's a bad formula for where we are 5 years from now, 6 years from now. That's why the urgency of this is extremely important, that we get ahead of fraud rather than constantly chasing it. Because when we're chasing it, we're also hurting companies that are the good actors that are trying to do it right. We are all for shutting down bad actors, aggressively going after that. But when the good actors made a mistake, made an error, but now they're having a difficult time making payroll on it, we're losing the good guys in this, and that's going to hurt us long term. So let me shift a little bit. With the RAC audits, Dr. Agarwal, you and I talked briefly earlier about this. The incentive for them to, if there's a question that this is going to get lost in an appeal, for them to not pull that, for them to actually work with them. I will tell you, you probably heard the term as well. Many of the hospitals and providers call the RAC audit folks bounty hunters. They come in, land, go through stuff until they find something, because they get paid based on what they find. So the incentive is not to be able to sit down with someone and say, hey, you made a mistake on this. Let me show you how to do this different. The incentive is, I got you, and I'm going to get paid. That's a bad relationship that's forming between our government and the people that we're supposed to serve. Now we've got a set up environment where the incentive is for them not to work with someone to find and work this out and how to learn on it, but to punitively pull a file. That's a whole different set of relationships there. So the question is, how do we get back to the incentive with the RAC folks to be helpful rather than punitive, but we still go after fraud? Ms. King, do you have an idea on that?
Sir, if I might, the other types of contractors that do post-payment reviews, the MACs, the CERT, and the ZPICs, are not paid on the incentive basis. They're paid on the basis of cost under contract. The payments for the RACs were actually established by law.
Right.
How they were.
Correct.
So that, if you're concerned about the incentives, it's something to consider.
I think that's a very helpful point. I would also say, we do provide, so I think, let me make 2 points on this. One is we do provide oversight to the RACs. So, the characterization that they might be on a fishing expedition or that they're making judgments just to receive the incentive payment is, I think, not accurate, because we do, again, do that validation work behind them to make sure that their accuracy rate is very high. That accuracy rate would not be maintained.
Is there an incentive to be helpful while they're there to teach someone how to do this better, or is the incentive to be able to pull it?
I think there's 2 kinds of incentives that work in the favor of providers. One is the RACs are equally incentivized to find underpayments to providers. They get the same contingency fee if they return money to a provider that they deserved as they would when they make an overpayment determination. That's just one. The second thing is we have made it a priority in the program, both for RACs and MACs and other auditors, to use education as a tool. So when deficiencies are identified, they can communicate those to providers, and hopefully providers can, rectify that deficiency going forward.
Are they paid for that, paid for the education?
Well, the RACs are not specifically paid for that, but the MAC contractors do work very closely with providers in all their regions to, teach them about Medicare policy and payment requirements. We also utilize the results of both MAC and RAC audits to alter our programs, be more specific on policy issues where necessary, make changes to processes. So that is a priority for the agency. We do try to use the outcomes of these audits to alter our interactions with providers.
So what is the incentive for them to educate?
I think what RACs have been able to do is take areas that we know have high improper payments in them, again, differentiating improper payments from fraud.
Right.
RACs are not necessarily designed to go after fraud. Those are other contractors and other areas of work. What we have asked them to do is focus on areas of high improper payments and make recoveries where appropriate. Along the way, they do identify educational needs or, clarity deficiencies that we can address either through other contractors or directly.
Ms. Norton.
Thank you very much, Mr. Chairman. Thank you for this hearing. When perhaps because Medicare is a necessarily costly program, I say necessarily, we do the best we can to provide maximum care for the elderly when they are ill. There is particularly concern when there are reports, and they are always quite sensational, reports of fraud or particular abuses in the program. And I note that the Affordable Health Care Act gave the CMS several new, or at least expanded authorities to deal with fraud, and I'd be very interested in hearing about how you deal with those at higher risk. Who are they, and how you deal with them when they apply, when it applies to providers and suppliers who are newly enrolling, and those who want to revalidate their participation in the program.
Sure. Thank you for the question. So as a result of the Affordable Care Act, we have been required to implement a whole new approach to provider enrollment and screening that takes into account the risk level of that category of provider. Higher risk categories of provider, like, say, newly enrolling DME or home health agencies, are subject to greater scrutiny. That scrutiny can include, or, everybody certainly gets certain data analytical work to make sure that providers of all types have the right licensure, have the ability to practice in their provider category. Higher levels of scrutiny also include site visits, criminal background checks, fingerprinting most recently. As a result of those activities—
Had you done fingerprinting before?
Fingerprinting we are just bringing online. We procured that contractor last month, and we are now.
For all providers or for these high risk?
The highest risk providers will be subject to the fingerprinting requirement. As a result of those activities, we have revoked, and through the revalidation process, we have revoked over 17,000 providers since the ACA and deactivated an additional 260,000.
For example, for what kinds of abuses or fraud, or is it fraud?
All manner of activities, really wherever they do not meet our requirements. So lack of appropriate licensure would result in a revocation. The presence of certain felony convictions on criminal background checks would result in revocation. Failure to disclose information required on the Medicare application or to report that accurately.
So would these providers be barred, period, permanently barred?
The actions that we take, of course, are governed by the authorities that we have. Revocation allows us to remove these providers for, I believe, up to a maximum of 3 years based on the infringement. Beyond that, law enforcement has exclusion authority that lasts for longer and is more sort of widespread in its impact. And we do work with law enforcement on utilizing that.
Have you had occasion to refer a number of these to the U.S. Attorney or other law enforcement?
Yes, we actively work with law enforcement on referrals, but also even prior to the referral. So I think we've given law enforcement an unprecedented access to CMS data, real-time access to our systems, the same that we utilize in our analytical work. And then as cases develop, we are in regular connection with law enforcement about cases that they may be interested in, and ultimately do make formal referrals that they can choose to accept. We also work with them on the entire investigational process as they deem necessary to provide them additional data or any assistance that we can.
I'm interested in this temporary moratorium. This is apparently a new authority under the ACA for new Medicare providers and suppliers. What would evoke that, and how does it work?
Sure. So since the ACA, we have implemented essentially 2 phases of the moratoria, essentially against home health agencies or newly enrolling home health agencies and newly enrolling ambulance suppliers in a few different geographies across the country. Before implementing that moratorium, this was a big step because it is I think, a notably important piece of authority that we were granted. Before implementing it, we worked very closely with law enforcement to make sure we were looking at the right geographies and the right provider types. We worked with state Medicaid agencies and across the agency, across CMS, to ensure that we were going after the right areas and also not having or potentially would have a deleterious effect on access to care. Well, we ultimately chose both the geographies and the provider types were markets that were saturated by these provider types, roughly 3 to 5% higher market saturation in home health agencies and ambulance suppliers than the average geography across the country. So far, the moratoria have been in place for, the first phase was put in July of last year, a second phase in January. We continue to monitor both cost issues as well as access to care, and we have not noted any access issues thus far. I would say the moratorium has been a useful tool. I believe law enforcement finds it a useful tool as essentially a pause in the program so that no new providers enter a geography and bad actors can meanwhile be rooted out. Just as examples of work that we've done, we have revoked over 100 home health agencies in Miami alone, more than half of those during the moratorium period, and 170 revocations of ambulance suppliers in Texas.
Now, how do you keep beneficiaries from being affected, particularly with that large number in one location?
Right. That is absolutely a priority of ours. We started by choosing areas that were very saturated to begin with. These are not areas where access to home health services or ambulance services was threatened in any way. Even MedPAC had agreed that both of these provider types, as well as the geographies, were appropriate to go after. Since implementing them, we have stayed in constant contact with the specialty societies that oversee these areas. We've worked with state Medicaid agencies, with CMS regional offices that directly receive complaints from either providers or beneficiaries to monitor for access to care issues. And as I stated earlier, we have not identified those issues so far.
Finally, Ms. King, have you had occasion, since these are new authorities, to look at their effectiveness and their implementation?
We have not. We we evaluated the enrollment process just as these new authorities were going online, but we have not been back to look at yet. But we concur that front-end strategies on the enrollment side, that making sure that the right providers are enrolled and the ones that are at risk for being fraudulent are prevented from being enrollment is a very effective strategy.
Thank you very much.
Let me just run through some quick questions, and then we're nearing the end, so the end is near. I want to confirm again the percent of patient files pulled for a RAC audit. You've used the 1% number several times. Is that accurate, around 1%, or you say 1% or less?
The 1% actually is not just the RAC audits, it's all the post-payment audits.
Okay. That's in every category, whether it be durable medical equipment, physical therapy, hospitals, labs, whatever it may be. In every category, it's 1% or less.
Yes.
Okay.
Well, the aggregate number is less than 1%.
That's what I'm asking. For each category, are there categories that are higher, that are considered more high risk, and so there are more that are pulled in that category?
I don't know the answer to that.
Do you know, Dr. Agrawal?
I can't answer the claim question, but in terms of prioritization, we clearly do focus on high improper payment rate areas. I think that's a requirement of the contractor itself, of the program, that we focus on areas where the improper payment rate is just much higher than in other areas. Right. So you would expect to see greater portion of audits in, say, for example, durable medical equipment or home health agency services, because those are where a lot of the improper payments.
But that's what I'm trying to figure out. Is that category higher than 1% of what's pulled?
You know, we can look into this, but I believe that most of the RAC audits are focused on the Part A side, even though that the rate of improper payments is higher in durable medical equipment and home health providers. But the actual dollar amounts of the improper payments are higher.
Sure. Well, yeah, it's a larger bill as well. Part A is going to be larger than what's going to be in Part B and most of the smaller providers. So I would understand that, but it may be large to them. So if you've got go back to the physical therapy clinic, privately owned, fewer number of patients there, it may be a very big deal to them to have 2% of their files pulled than it would be to a hospital, as far as just general overhead. Okay, Dr. Agrawal, you mentioned as well about good actors in this. The possibility, and I heard a lot of, variances of that to put in the maybes possible. We're looking at statements in it for good actors that are out there. Once they've gone through, they proved it to do well, they didn't have a lot of inaccuracies. How do we slow down the process so they're not coming just as fast to them? Again, coming to, an entity that's set up to do compliance now more than it is to take care of people. Where are we on that? Give me the process.
Sure. So one solution that's been proposed is to lower the volume of medical record requests that could go to a provider that in previous requests has actually had a low denial or overpayment determination rate. That, I think, is a good idea. We've heard it from a number of sources, and we are implementing that approach in our next round of RAC contracts, precisely so that providers that have been audited, that have done well in the audits and shown that they're following the rules, will face fewer audits and lower volumes going forward.
Okay, is that less frequency of audits, or is that they're grabbing a smaller number of files when they come? They're coming just as often. They're maybe just doing half of 1% rather than 1%, or are they coming maybe only once every 2 years, so they're in their building less often?
I'd have to confirm. I know that the volume, per audit will be decreased, but I'd have to confirm if the frequency would also be.
I would just recommend you both are important, especially to Part B folks. They're trying to run a business, and if they prove to be good actors in this, the frequency matters to them. When they have to stop, now obviously the volume that is being withheld from them, not being paid to them, makes a big difference for them making payroll, but it's also extremely important they're able to focus on their business and not every 60 days, 90 days have to stop and do another one of these if they've already proven they're doing well, they're following the rules. So I would recommend to you both are examined on that, both frequency and number of files they're pulling. Has there been a study to look at the compliance cost for the providers? Mr. Ritchie mentioned before around $700 million has been recovered this year. Is that correct?
Yes.
Okay. Do we know what the compliance cost is? Has anyone seen a figure for that?
Not to my knowledge.
Because with most of the regulations that are out there, when they're promulgated, there's an estimated compliance cost for the promulgation of the rule. It has to go through based on the UMRA requirements. The question is, do we now know with more certainty what the actual compliance cost is. Where would I get that?
I'm not aware that such a study has been done. We have not done one.
Okay.
Yeah, we haven't either. I'm not aware of it.
Okay. I can go back and look at the beginning, because when it was originally promulgated, there would have had to have been an initial estimate that was put out at that time as well. I'll go back and pull that, and we'll work through that on our side, since we don't know of another one that has been done since then. Last set of questions here on this, the pausing the racks. Minister Tavener and I have had a conversation that when there's an intermediary change, very typically when the intermediary changes to a new one, what happens is the old intermediary starts losing employees quickly, and they're trying to still maintain all the rack audits during that time period with fewer and fewer staff, but everyone's leaving because that company is shutting down or shifting to a different spot. The other company is still trying to fire up and to be able to get ready, so it's very slow. But the speed of racks can be the same across that. Though the old intermediary can't keep up and the new intermediary can't keep up, and you've got a drag there in response time. So my conversation has been, can we reduce the number of racks during that transition time when the intermediary changes? If the authority exists to do that, where's the authority to also slow down the process to allow us to catch up on this backlog somewhat? To look at it and say, we're still going to continue to do this, but we've got to slow this down. Because if we're approaching 1 million files sitting out there with more still coming, they will never catch up. It doesn't matter how much we fund it. We're not going to catch up, and that's a lot of money to be held from individuals. What is the conversation out there related to that?
Yeah, so we do realize that as we procure the next round of rack contractors, that there is a sort of transition issue. What we have done is pause the rack program during this transition. What we don't want to happen is for one contractor to initiate an audit and for a second contractor to then complete that audit. So we are working to
happens all the time.
We are working to avoid it this time. So the last round of audits were initiated or were permitted to be initiated at the beginning of February. Those audits must be completed in a timely manner so that, and then the current batch of racks can wind down, and then the new batch of racks can wind up. During this pause, we are also, using it to, taking advantage of it to alter the rack program based on input that we've gotten from providers and other stakeholders to make it more transparent to providers, to provide more education, and to make sure that it's focused on all areas of improper payment.
And when will that be public?
The procurement process is going on right now. We are following, sort of standard Federal procurement requirements. There are statements of work that in order to actually get proposals that either have hit or will soon hit, public transparency, and contractors will be able to respond to.
Okay. Any other final comments? Bill, I appreciate you.
sir.
Okay. I appreciate you being here and for the conversation. Your work is extremely important, both in transparency and in helping us deal with improper payments and fraud. But I think you've heard from this committee pretty clearly, we need the balance. We need providers. Right now, with what's happening in healthcare across the country, we're losing providers. And anything that discourages a provider from continuing to stay open makes the problem worse. We have more seniors every day joining into Medicare, and we have a problem with providers staying in based on reimbursements and based on just sheer compliance and the frustration of that. This is reaching a really bad spot, and we've got to make sure we're working with providers to keep the good actors and then weed out the bad actors and educate those that just made a mistake rather than push them out of business. So with that, we're adjourned.
Thank you.